politicians getting involved, such as politicians not directing what is our medical directives. But as Jen Sachs answered earlier, in the steps that are being taken on the federal level for our projects, we've enhanced protocols for patient screening, efforts to better match drugs to patient tolerance. We've put in risk-based protocols to assess patient eligibility on take-home dosing. We have patient monitoring protocols in place. Actions to address diversion have included switching to observed dosing, transferring to different support services, or removing those who should not be in those programs.
Okay, so if those items aren't happening, will the lack of those things happening that you guys have just identified mean that you will not fund programs through SUOP?
That is correct.
Okay, so if there is evidence of diversion that is happening from SUOP program funded so-called safe supply programs, that funding will cease, and will it cease immediately?
At this point in time, the protocol measures have been put in place and they are constantly being monitored.
So how soon after diversion is found to be happening from those exact safe supply programs that your government is funding, will your government act to cut off that fund?
I'll refer to Jen Sachs.
At this point in time, what we are doing is working with all the projects to ensure that they are putting in those robust set of safeguards and measures. And we will be there will be regular reporting. We have open line of communication with the projects, with law enforcement, all of these. And so we will be regularly monitoring and then making adjustments as needed.
I think it's really sad for Canadians that the government refuses to give an answer as to what they would do and how quickly they would act if they found that something absolutely illegal was happening, to actually act to cut off funding to save the lives of Canadians. I think it's absolutely shameful that they're allowing gangs to profit off the death of Canadians that they are funding.
Care to take a few minutes to respond to that, or shall we move on?
That wasn't a question.
It's a statement.
All right. Maybe the next person will afford you that opportunity. Mr. Pawlowski, Dr. Pawlowski, please, for 5 minutes.
First of all, I'd like to table a motion, give notice of motion, that pursuant to Standing Order 1082, the committee undertake a study of the treatment and prevention of cancer in Canada, including the state of current research on diagnosis and treatment of cancer, that the committee allocate up to 8 meetings to this study, that the committee report its findings and recommendations to the House, and that pursuant to Standing Order 109, the government table a comprehensive response to the report. I wasn't going to go here, but I've heard the testimony, and Jennifer, I know you're locked in conversation there, but you did talk about diversion and safeguards for diversion. So I don't want to make my 30-plus years of being a doctor totally useless. I kind of listened to the safeguards, and I had some questions. So you say screening of patients. I've been doing this for 35 years. When I started, I used to think I could tell who was reliable and who wasn't. And I remember literally seeing a nun who came in and wanting, I don't know, she wanted benzodiazepines or narcotics and stuff. And I said, oh, of course, she's a nun. Like, I'll give her a prescription. She's honest. And then a guy comes in with a lot of tattoos and a kind of a muscle shirt, and you say, well, I ain't giving him to him because he's unreliable. And in the 35 years since, I cannot figure out beforehand who's going to be reliable and who could possibly be selling it. Even I would say if you get to know your patients well, you don't know. Even the grannies, these little grannies that come to you and say it's because of their bad arthritis, you don't know that they're not selling it. And I've heard it from the cops. They know places where the old people go and they sell it to dealers. As to an agreement, I mean, if somebody's going to sell the drugs, I don't think you're going to trust them to make an agreement with you and sign a paper and, okay, you can trust them now. As to the regular urine tests, those tests are positive, negative. I've seen those. I work in a clinic that does them. It's positive or negative. So if you give somebody 8 dilaudid tablets to take home, all they have to do is take 1. Go sell the other 7. Your urine's going to be positive one way or the other, right? So that wouldn't seem to me all that reliable. I think you had some other safeguards. I think there was protocol for dealing when diversion occurs, but do you have other protocols? And let me just mention briefly in passing, I think the British Columbia Officer of Health, in reviewing the safe supply situation, actually recommended that the fallback position be observed treatment, which I'm not sure what the recommendation is with reserve treatment. Yaris repeatedly mentioned Switzerland. Switzerland, all the studies with HAT, heroin assisted treatment, those are all observed treatments. And I've certainly, in talking to a lot of experts in addictions, they've been looking for the same thing, which is observed treatment, possibly with intravenous fentanyl or oxycodone. But it doesn't seem like there's funding there at the moment for it. Is there contemplation of providing more funding? In fact, some of the addiction people I talked to, they said the pills, going home with the pills was kind of the poor man's choice because they didn't have the money to do observed treatment, which is where the evidence is for. So I wonder, like, I got off topic. If there's more safeguards, you can talk about that. But also, how about in what's the plan in terms of the possibility with the real hardcore addicts, as in Switzerland, that they provide directly observed treatment rather than pills going home?
So a couple of points. Thanks for that question. I think it's important to note that it's a suite of measures. It's not one or the other, so it's a suite of measures. Part of those measures include absolutely having the capacity to have witness dosing based on assessment or any indication that there may be diversion, includes random and regular urine drug screening. As part of these projects, some of it is witness dosing. It is not all just hydromorphone tablets. There are some injectable programs. There are a variety of different medications. We are also requiring that projects provide a range of kind of backbone medications so that you could reduce the amount of additional kind of safer supply or prescribed alternatives that a healthcare professional may want to prescribe to a patient. So it's a range of measures that are being taken. There must be the capacity to witness depending on the assessment and working with them. There are projects that absolutely have injectable and other observed dosing. I will note in Switzerland that with heroin-assisted treatment, and I'll pass it on to my associate deputy who is just there, but they do have witness as well as carries in that case. And all of this is being undertaken with regular monitoring, reporting, and evaluation that is being undertaken that will inform our work.
If I may, Chair, the only points I would add is, I mean, to your point, I mean, really what we've done as a part of our efforts to really take a close look at projects, understand the risks, is really through consultations with, those in, experts in addiction medicine, understand what is the top tier, what are the top threshold of safeguards that can be put in place when dealing with substitution therapy of any kind, when a narcotic is involved, and then apply those in the context of these projects. And to the earlier question about, we would be prepared to move very, very quickly where we see, where we encounter evidence of systemic harm. And yes, just on the point of Switzerland, we're very
Thank you.
Very interested in the work being done in Switzerland with their heroin-assisted treatment. They do 7-day carries now as a part of an unsupervised dosing program, which we've studied very, very carefully to try to take as much from their experience as we can and apply it in Canada.
Thank you. Monsieur Thériault, pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. So, yet again, a technical question. During the government's November economic statement, the Minister of Finance announced an intention to remove GST and such taxes on counseling services. And in Quebec, people are wondering they will benefit from the removal of these taxes. Educators are asking whether they too will be covered by this. And if you can't answer, could you provide us with a written answer? Thank you. Honourable Minister, in the RCMP drug seizure, you tell us that we can't tell where this came from, but what can you tell us about the source of these seized drugs, prescription drugs? How come all this is in the hands of organized crime? Thank you for your question.
By making sure that we are all on the same page about diversion. Diversion is illegal. It is illegal in all contexts in terms of all drugs and all medication. And I'd say that diversion happens with pain medication, ADHD, anxiety prescriptions, and so on and so forth. And, you know, the question that we're always asking is how much diversion are you willing to accept? Because it happens in all of these spaces with all of these prescriptions and in many different scenarios. And we aren't stopping healthcare provision in those instances. So if we are looking at hydromorphone and prescribed alternative within the same context of healthcare provision, then we have to look at it through the same lens.
Bon, je comprends que vous pouvez.
All right. I understand that you have worked up these principles that you've told us of today, but I certainly hope this is something that you'll look into in greater depth. It would be important to do so. Probably the RCMP must carry out its investigations and come up with evidence and present it. I understand the legal constraints on information sharing, but at least tell us that you will get answers and that you're looking for answers, because this sheds great discredit on the entire program of harm reduction when you see news to this effect with it can be, used to support various narratives. So do you agree? Will you make efforts to get back to us on this matter and tell us what you will have learned about this? And do you have any specific concerns to ensure that follow-up is carried out, yourselves involved?
Thank you. And as I've said previously in this committee, I take, as does the department, takes diversion very seriously, which is why we began with the protocol review that we did with our programs, and we will continue to do that work. And the department can provide you with a briefing on what we are doing in working collaboration with law enforcement.
Thank you, Minister. Last round of questions for this panel will come from Mr. Johns. The next 2.5 minutes, please.
Well, thank you, Minister. Minister, before I get into my question, in terms of Wellness Together ending, this deeply concerns me because I want to know what's going to fill that need going forward. And also the bilats, they're not good enough. We saw PEI. They said they're spending zero money when it goes to mental health. And I hope you'll work with me on this. But I want to get to, Minister, we heard the Conservatives take on the attack on Dr. Sereda earlier in committee. And Dr. Sereda posted on X in a response to Adam Zivo, who's a freelance writer and weekly columnist at the National Post. He published the small city where she lives not once, but 3 times. She cited that she didn't feel safe in London, Ontario, due to a history of domestic violence. She's moved numerous times, eventually had to move to a new location to be safe. She protects the info where she lives very closely. Nothing is available online. She said her address is actually very hard and difficult to, not very easy to find. Others have joined in and mentioned the town where she is and where her kids are online. Now, Dr. Sereda contacted Adam Zivo. She said she moved to be safe from domestic violence, and his posts have made her feel unsafe. His response, it's in the public interest to know where she lives because she doesn't live in London, where she prescribes safer supply. So, he says that public interest is as important as her privacy despite her safety risks. Police contacted Adam Zivo. He apologized and said he understands he shouldn't have posted it, but he still refuses to remove the post. He has a pattern of attacking and slandering Dr. Sereda. Dr. Sereda has experienced harassment, vulgarity, and more from his followers. And even after he knew about the safety risk, he posted it again, even saying her address is easy to find. Sounds like a call to action challenging his followers to find her. Not something you say to a woman who has asked you 3 times to take down her safety. So I'm asking you, Minister, what are you going to do to protect